All right. So, just as a follow-up, one of the things that a lot of times we don't talk about in many courses, but particularly with you guys, seeing a lot of baseball players and everything here, one of the courses I talked to Cindy about including was something about ulnar collateral ligament, because it is an interesting topic, and as we learn more and more about it, we're seeing, unfortunately, I think, more and more UCL reconstructions that are being done around the country, and particularly in younger, more active kids, because the volume of baseball and the development of baseball is so repetitive and so proliferative that many of these athletes are tearing their ulnar collateral ligament at very young ages. And it's very alarming, but at the same token, there are a lot of surgical procedures that can be done to make sure that it doesn't lead to an alteration of their life, and in many cases allows them to get back to baseball. So just wanted to cover this, some of the basics of what we go through in ulnar collateral ligament reconstruction, even though it may be something you don't see a ton on a day-to-day basis in your clinic, and then again, maybe you do see it every day in your clinic. So people talk about a UCL reconstruction. If we want to be really technical, it's a medial ulnar collateral ligament reconstruction, not a lateral. There is a lateral ulnar collateral ligament reconstruction, but that's a very different operation, and it's done much less frequently. Typically in trauma, not certainly from throwing or valgus loading, because that ligament, as we talked about, gives you varus stability, the lateral ulnar collateral ligament. This is simply the medial ulnar collateral ligament, and it started with the Tommy John procedure. The first person that we know of that's documented that had this procedure done was Tommy John, and he was a real person. Some people kind of laugh and think that it's not really named after somebody. It actually is a real person, and Dr. Job, he's in the lower right part of this slide, came to, when he examined Tommy John, said that I have a procedure that we could do for this, but I'll be honest with you, I've never done it before. And you'd be the first person they're going to do it. And Tommy John knew that if he didn't have it done, that his career was over anyway. So he said, "Yeah, let's try it." And Dr. Job did it, and he went on and pitched for several more successful years in the major leagues.
How long was his rehab? Do you have any idea?
Yeah, they never talk about how long his rehab was and kind of what he did. I haven't seen anything with that. They do talk about his career after, and he was able to throw for several more seasons. I mean, if you look at his baseball card, I was in D.C. 2 weeks ago, and there was a talk on this, and somebody had found a Tommy John baseball card, and they took a picture of the back side of it somewhere, and it showed all the different years. He'd thrown for a long, long time. He had a very, very good career. But I don't know the specifics of his rehab. I'm sure it wasn't anything like what we rehab now and whatnot. So Steven Strasburg, real high-profile baseball player, tore his ulnar collateral ligament, and there's been a lot of talk about the rehab he went through, and a little bit about the inverted W, some of the different ways that he throws that maybe might have set him up. There's some theories about that, but certainly there's a lot of media coverage on this particular injury. So your patients that come in with this, they ultimately know a lot about it, have read a lot about it, and even people in the general public know a lot about this procedure because it's out there so much on ESPN and all the different things that we see in sports. Why does it occur? It occurs with repetitive loading of the ulnar collateral ligament with throwing, and some people would say that they can feel it on one particular pitch, but we probably know that it's not really from one particular pitch per se, but it probably was partially torn or ready to be fatigued and torn by all the subsequent repetitions that came before that. Many of these individuals, as we saw in our sample of the ulnar collateral ligament or medial opening study that we did with valgus opening, those pitchers, they started at age 8, 9, 10 and have pitched for many years. So there's been a chronic loading of this structure kind of over time. So it's not from one repetition, although often they can recall when it happened. The ligaments, just talking about the elbow ligaments and stability, I think this is kind of something to keep in mind. This is from Ann and Morey, classic study in 1993 from Mayo Clinic. They showed us that the valgus force in extension, when the elbow is fully extended, is 31% in the medial ulnar collateral ligament, 31% in the bony articulation, and 38% from the joint capsule. So it's a shared, and it's obviously very close to being thirds, 1/3, 1/3, 1/3, as far as how the stability or the force attenuation is broken up and sort of taken responsibility for. It changes significantly in flexion. So as you flex the elbow, all of a sudden the ulnar collateral ligament is under a much bigger load. It takes up 54% of the load as opposed to only 10% in the joint capsule, because the joint capsule is no longer in a taut position because the elbow's in flexion. So that's the big difference. There's an increase. The bony articulation, you can see 33% in flexion, and it's 31% in extension. So it really doesn't change significantly. The significant change is there's offloading of the joint capsule, and what absorbs that is the medial collateral ligament, medial or collateral ligament. 90 degrees of elbow is a position of elbow function. We know that as we go through the cocking and then acceleration phase that our elbow is flexed in that position, and that shows the increased role of the medial ulnar ligament. The varus torque. So a varus torque is something that overcomes a valgus load. So the varus torque that's needed to stabilize the elbow at maximal external rotation is 64 Newton meters. And when you go to a laboratory with a cadaver and you load a human medial ulnar ligament, its ultimate tensile load is 32 Newton meters. So every throw, we have a force of 64 Newton meters that goes through the medial elbow, but yet the tensile load of the MCL, the medial ulnar ligament, is 32. So you can see every throw we conceivably would actually rupture our ulnar ligament if it wasn't for the bone and it wasn't for the musculature. So for us as physios, I think it's important to realize that this is an area that the dynamic stabilization, it clearly shows how important dynamic stabilization is, that we need to keep working on that and have very good muscular support, both proximally, distally, and at the elbow, to be sure that we are able to overcome that 64 Newton meter load. Inverted W at foot flat. This is something, this came from a very reliable medical source, ESPN. But they're very technical, believe it or not, even though you joke and say, Sports Illustrated, ESPN, you know, what's with these guys? But they've looked at when the pitcher puts the front foot flat, how pitchers who have had ulnar collateral ligament reconstructions or have injured that, have this inverted W, which means there may be some catch up and some increased valgus loading at the elbow because of this position. And it's a fairly common one that many noted pitchers have, and very successful pitchers have, that have ultimately led to ulnar collateral ligament injury and subsequent Tommy John procedures. So let's talk a little bit about the rehabilitation, and first a little bit about the surgery. Obviously I'm not a surgeon, so we'll just talk about a few salient points. But some of the things that we need to know when we look at the procedure, we look at somebody with this type of surgery, is knowing if the flexor pronator has been exposed. Have they actually had to reflect? In the classic Tommy John procedure done by Dr. Joe, the flexor pronator was violated. So they actually had to take the flexor tendon, cut it, lift things up out of the way enough so that then they could take the graft, pass it in a figure-of-8 fashion through these bone tunnels. And it's a very successful stabilization, it's a very strong stabilization, but it actually meant in that early phases, depending on the type of procedure, that not only was there a reconstruction of the medial elbow, but there had to be a repair then of the flexor pronator tendon. So early on, you wouldn't want to do a lot of wrist extension stretching to stretch that, or forearm supination stretching, because that would actually pull on the tendon. So the gold standard for this is to actually use the ipsilateral palmaris longus graft. People who don't have it then would have the contralateral done, or they could use other structures such as the gracilis, sometimes use tendons in the foot. There's a number of different things that can be used. The palmaris longus graft, which again has classically been used, has a strength of 357 newtons. So it's a very, very strong graft. The human UCL is 260 newtons, so it's actually stronger than the medial ulnar ligament in its native form. Oftentimes during the surgery, there is an ulnar nerve transposition, as we just got done talking about. Typically it's done not submuscularly, which if it's submuscularly, you would have to reflect the tendons back, again, violate the flexor pronator tendon. It's actually done in a drawing a blank on the word here, the fascial sling. So the fascial sling is done just under the skin, so it's very superficial, and it's not suspect to compression by the muscle as a submuscular one would be. So the fascial slings are made truly by fascia in several locations, and the nerve is just relocated from the ulnar groove medially in the bulk of the forearm. Here's the look at the palmaris tendon graft that is used, and it's a relatively robust structure that can be taken out through some very small little incisions with a harvesting type device. Now there have been, through the years, there's been a number of different procedures that have been used that help us in physical therapy because it means there's less surgical exposure. And they've changed the way the fixations are. The DANE procedure, or DANE procedure, DA stands for David Alchek from Hospital for Special Surgery in New York. NE stands for Neil Elatraj, who's in Los Angeles, works with the Dodgers. So Dr. Alchek with the Mets. So you basically had these two guys kind of inventing and talking about this procedure that they then called the DANE procedure. And there's a number of good outcome studies with this. And this is a very good, in various surgeons' hands, a very good way to modify the way this particular procedure is done. Another thing that's become very popular by the group with Dr. Andrews and Dr. Paletta here in St. Louis is the internal brace. And this is something where the tendon may be partially torn, or it's a tendon, the ligament may be partially torn, or there may be the ability to actually repair the ligament, the native ligament, and then a structure is placed over it called an internal brace, and that's a very strong, almost like a tape type of structure that's actually sutured over the top or in addition to the ligament to structurally reinforce the ligament. So it's called internal brace, and this is not unique to the elbow. They do it for the anterior talofibular ligament. There's a number of places around the body that this particular device can be utilized to give stability, but it's becoming more and more popular because this is a very robust repair that occurs, and it's a very, very strong construct. And the thought by most individuals that are doing these is that the rehabilitation, instead of taking up to a year for a traditional Tommy John or ulnar collateral ligament reconstruction, that the rehabilitation takes roughly 6 months. It's about half. Players are actually back throwing and actually in competitive situations in about half the period of time from the traditional Tommy John procedure. So for many people, youngsters for example, or perhaps even very old players who can't miss a complete season at this stage of the career, it is a potential option for somebody to get very good stability, but at the same point not miss as much time as far as their rehabilitation and surgical time.
Is that just a polymer?
Say it again?
Is that just a polymer?
I don't know exactly what it's made of. That's a very good question. I'm not sure the exact construct of it, but yeah, it's not a it's not human material. It's not from an animal or something. It's something that's constructed.
So it's on top of the tendon graft?
It sits in and around. So exactly, they stitch it in and they suture it. There's actually suture anchors that are done, and they would try to do a primary repair of the ulnar collateral ligament. And sometimes primary repairs work in and of themselves. But this ensures, with this internal bracing, that you have a very strong construct in addition to repairing and using the native ligament. They work the native ligament into this tape or into this structure, the internal brace, as best they can.
Do they have long-term studies on this yet? Or
Long-term is in like 10-year? No. I think some of the first ones have been done 5 to 7 years ago. So I mean, it's not something where they've only been doing them a year. They're becoming more and more popular. You've seen quite a few of them?
No,
No,
I've seen one.
you have one, so right.
Is it
So
mobilization?
Well, mine was a reconstruction, and then they augmented it with the brace, so it wasn't a repair.
right. So but I mean, did you actually have a Tommy John along with it? They use.
Yeah, they did the palmaris longus graft, but they
And then
added
they
it to
augmented
the
with
brace,
that,
because
okay.
I think mine was just a smaller graft, probably.
Okay.
Do
Maybe.
they start moving sooner? Do they start moving?
Yeah, they move them really soon. We'll show the traditional Tommy John, which is very early motion, but with the internal brace, they move it even faster. And the rehabilitation time, for example, plyometrics and some of the pre-throwing intervals, you typically start around 4 months maybe on a Tommy John. These basically at 8 weeks, they'll let you start doing some light plyometrics and even think about throwing in about 3 months.
Well, and Dr. Paletta spoke to us at some point, it was probably a year or two ago now, but his emphasis was that he's very specific on it has to be the right type of tear in the right location, it has to be the right age group, it's not, the repair isn't possible for everyone, it has to be the right tissue quality, so.
The key thing there is it's not for everybody. This wouldn't always work, and it wouldn't always, it's not like you got a hammer and everything looks like a nail kind of thing. It's a great adjunct to have. It's really good in certain situations. but there's a lot of people who still do the best with a traditional, the traditional Tommy John, the real ulnar collateral ligament reconstruction is probably one of the more successful procedures that we have. If you look at the long-term outcomes and whatnot, the return to not only full activity, but to the pre-injury level of activity. So going back at the level. So a major leaguer injures their elbow, they don't just get back to the minors, or they just don't get back to throwing, 2/3 of their velocity. Getting back to truly full activity, there's a very high successful outcomes, higher than any shoulder procedure ever. Rotator cuff repair we know is dismal. Slap repair we used to think was good until we started looking at the outcomes to pre-injury levels. Tommy John's by far and away the most successful that they have. I mean, people really do come back after this surgery, and there's every team has multiple people on their pitching staffs that have had this procedure done. It's so successful that kids are actually ready to have it. And there's actually documented, surgeons that have said that parents have brought kids in to say, will you do a Tommy John on my kid's elbow? And they said, well, did he injure it? He said, no, we just know that people come back and they throw harder. We want our kid to throw harder. And they actually, people actually want this to be done to them. Obviously, that's unethical and not being done, but the idea is the kids think, oh, if I have a Tommy John, I'm going to throw faster, because the word on the street is that if you have this done, you do come back and throw faster. And there's some evidence to say that in time you may throw faster. But one of the reasons that many individuals who are very skilled in this area think that people do throw better is not necessarily solely from the reconstruction, but the fact that they spend a year rehabbing and doing strengthening and working on their whole body, from their core to their legs to their shoulder. And imagine spending a year in rehabilitation and rehabilitative exercise, what that would do. And there's no control group yet for saying, hey, you're just going to be sit out a year and you're going to do strengthening, and this group has a Tommy John to who can increase velocity more. But one of the thoughts is that. And this picture is just there. This is Mike Reinhold, who's with the White Sox now, used to be with the Red Sox, but has done a lot of work on the ulnar collateral ligament. And these are just young people that have come to his clinic up in Boston. He sees many, many young throwers that have this procedure done. It's happening more and more now. And Dr. Andrews in Birmingham, in his talks, he talks about how, for the first 10 or 15 years that he did the procedure, there was a super small number of individuals that were under the age of 18 that he did this on. Now that has blossomed, and it's a significant part of what he does every year is UCL reconstructions in young throwers under the age of 18. So talking a little bit about the postoperative rehabilitation. One of the things not to forget, this is Josh Dine's classic paper looking at GERD, loss of shoulder internal rotation, among individuals that have ulnar collateral ligament injury. And it's definitely, there's a significant difference in people with ulnar collateral ligament injuries and the normal population and who has GERD. So it's very commonly associated that people who have lost interrotation range of motion in their shoulder can have that association with having an ulnar collateral ligament injury. So that's something that shows us, both from an injury prevention standpoint as well as in a rehabilitation standpoint, to make sure that we optimally work on the individual shoulder. And so right now I have three patients that have internal brace UCL reconstructions or repairs, and of those, only one of them has normal rotational range of motion in their shoulder. The other two were specifically working on shoulder range of motion to be sure that they're left with symmetrical total rotation. We don't want them to go back and start their throwing program with a loss of rotation in their shoulder. Josh Dine's paper shows that that's definitely a risk factor. So this is a paper, it's in your handouts, one of the ones I included. I was very fortunate to be able to kind of put this paper together with Dr. Alchek and with Dr. Andrews and obviously Kevin Wilk as well, just sharing the protocol and some of the things that happen. And it's from Sports Health, one of the journals for in sports medicine and whatnot. And it shows some it's got charts and follows basically the protocols. And what we use, we sort of use the protocols from Dr. Alchek and from Dr. Andrews to put this together as sort of a composite protocol, if you will, for ulnar collateral ligament reconstruction. And so, some of the early things that you see, and it's a little hard to probably see the things on the screen, but when you see the patients in the first week, there's obviously a great deal of swelling, they're immobilized. There's a posterior splint where they're in 90 degrees of elbow flexion. Many times the patient may be traveling back from wherever they had this, or they may just be at home, not in rehabilitation, but for the first several days they have a compression dressing on their elbow as well. But they start early on doing gripping exercises, some light range of motion of their wrist, and they're typically started on shoulder isometrics except for the rotational exercise, the internal extra rotation, which would give a valgus load to the elbow. So you don't want anything to truly give a valgus load to the elbow in this early phase, but you also want to make sure that the individual is moving their shoulder, that you're doing some scapular stabilization, some actual exercises at the elbow, the shoulder rather, so that the individual doesn't begin to weaken at all, because that's a big part of coming back. In week 2, they take the 90-degree splint off, and many times now, instead of an actual splint, they come with a hinge brace that there's locked at 90, and then you're able to just unlock it and then dial in ranges of motion. As you'll see, they're slowly or gradually going to gain range of motion using a certain protocol. The beauty of these things too is that each surgeon has a protocol, and usually they're pretty specific on, I want them to go, in this case, from 30 degrees to 100 degrees. So minus 30 degrees of extension to 100 degrees of flexion. And you initiate things like wrist isometrics, elbow extension flexion isometrics, and certainly the shoulder work proximally to be sure that they're strengthening. Week 3, the brace is advanced to minus 15, so from minus 30 to minus 15, and then all the way from 100 to 110 degrees of elbow flexion. So you can keep increasing, gradual, kind of a sequential, and different protocols, and I've done them from multiple different surgeons. Some will move that usually in 5 to 10 degree increments on each side, extension and flexion. Some differ very slightly, but there's usually a general consensus of how we progress that. So this kind of just really summarizes some of the things from the last slide that I just read off to you from our article. You really want to be, again, careful to be sure you don't do any valgus load. That's the one no-no, if you will, in these particular patients. They're quite aggressive at getting elbow extension range of motion and elbow flexion range of motion back. We just don't want to have a lot of gapping or loading in a valgus direction on the elbow. A lot of scapular work. This is just from Dr. Job's work in 1984. It's a landmark paper just showing how important some of for example, here the serratus anterior, high levels of serratus anterior activation during the acceleration phase. So obviously pointing to how important some of the proximal musculature is. And so early on in our initial evaluation, we want to look. This is a young thrower, came in. He does not have a UCL reconstruction, but this is a common presentation of scapular dysfunction in the young thrower. Many of these people who have ulnar collateral ligament reconstructions do have scapular dysfunction, so it's obviously something that we can work on. Again, some of the things we do, just ball circles, ball slides, just some things to encourage some elbow range of motion in a safe position, as well as, again, some scapular stabilization. We do some mobilization and stretching of the elbow. Sometimes players have had a long-term flexion contracture, and so it's very difficult for them to get their full extension back. And so one of the mobilizations that we would do to gain extension is a posterior glide of the ulna relative to the distal humerus. And just to remember that there's this angulation of the distal humerus in a 30-degree anterior position. So when you do that, you want to make sure that you slightly flex the elbow, and then that you're mobilizing on a 30-degree angle in a posterior direction, not going straight posteriorly. So our techniques for gaining range of motion: low load, prolonged stretching, putting them on a towel roll, for example, multiple times through the day, and just having the weight of the arm extend them if they're having difficulty gaining to the range of motion parameters in the first several weeks. So we can, if there's long-term loss of range of motion in the elbow, we can use things like the jazz and the Dynasplint, which do show some evidence, but that wouldn't be used in the early phases. That would only be interjected after there's been a range of motion complication. In most cases, with the early aggressive nature of the rehabilitation today, the range of motion is not much of an issue. It usually happens pretty good. But these are two examples of low-load prolonged stretches where you can use a slight weight, or you can use a piece of elastic resistance. You can see both of them have the towel roll proximal to the olecranon, just to form as kind of a fulcrum, if you will, to help with the extension range of motion. This is a technique that we would not use, high load brief stretch, so we obviously use very low loads to protect the healing ligament and construct, as well as to just foster true plastic deformation of the tissues. Joint distraction can work very nicely, and you can alter the position of elbow flexion to basically preferentially stretch different amounts or different locations of the capsule. So for example, if you're in a fairly neutral position, again remembering that 30-degree anterior angulation of the distal humerus, you want to pull forward at about a 30-degree angle with your distraction when you're in a flex position or a neutral position, mid-range position, if you will. when you're in full extension, the anterior capsule is very, very taut, but the posterior capsule is not. So any distraction that we would do towards full extension would obviously bias for the anterior capsule. And then if we do our distraction mobilization with the elbow in a flex position, that would actually work on the posterior capsule to a greater extent because the anterior capsule was very slack. So depending on what position the elbow is in, we can work on different portions of the capsule as we do that movement. Here you see a distraction type of motion on that angled position in 90 degrees of flexion to try to distract and create some stretch to the posterior capsule to try to encourage elbow flexion. Again, many of these individuals don't have range of motion complications. I just wanted to mention a couple of slides in the event that they do, that you're prepared with an armamentarium of mobilization techniques or different types of stretching techniques to address that. And here's again that angulation that we would use for a posterior glide. Week 3, I mentioned minus 15 to 110 degrees of flexion, and then thereafter on a weekly basis, they continue to progress in 5-degree increments in extension and 10-degree increments in flexion. So it's a very gradual kind of, they got a hinge brace. We use the hinge brace to give the support and kind of guide the range of motion sequencing so that they work towards full extension. So by week 4, they're from 10 to 120 degrees. We believe we increase the resistant exercise for wrist curls, forearm pronation, supination with a counterbalanced weight. We start a lot of our shoulder isotonic exercises, elastic resistance exercise, particularly for shoulder intralex rotation. And then by week 6, the brace is almost ready to be discontinued as the range is 0 to 130 degrees. Somewhere between week 6 and week 8 is when most of the surgeons will actually let us discontinue the brace altogether on these particular patients. So just a couple of pictures of the pronation, supination, radial ulnar deviation, wrist flexion extension, very, very non-romantic or very non-creative ways of just basically doing a lot of wrist and forearm exercises. So it's pretty basic. Just a little bit about some of the literature about the moment arms of the elbow. This is a picture I had taken of myself. I was down doing a spring training thing with the Rangers, and they took my picture, just kidding. But anyway, what are our elbow flexors? The muscles that flex our elbow are the brachioradialis, biceps, brachialis, and your extensor carpi radialis, believe it or not, is a pretty good elbow flexor. Our elbow extensors are their triceps, flexor carpi ulnaris. You say, well, wait a minute, elbow extension, a flexor, based on the angle of pull, the flexor carpi ulnaris is actually an elbow extensor. We have our anconeus as an elbow extensor, as is our flexor carpi radialis. So 2 of our flexors of our wrist are actually extensors of our elbow. So it's just interesting to know. Then as far as stressing, they're either the varus or valgus moment. So remember, a valgus moment resists varus stress. So our anconeus, so brachioradialis, extensor carpi radialis, and extensor carpi ulnaris all resist varus stress. Where we're the most excited usually is to resist valgus stress. So these muscles create a varus moment. Our pronator teres, our flexor carpi radialis, and our flexor carpi ulnaris. So making sure, we talked about the 64 Newton meter load of every throw versus the 32 Newton meter load ultimate failure of our ulnar collateral ligament. This is what we have to build up in the reconstructed elbow, is to be sure that we have very good dynamic support of the elbow to help guard against any re-injury or excessive stress that's placed onto those structures. So we oftentimes can, in the early phases, take the weight and put it proximal to the elbow, but we begin doing the Job exercise, the same exercise we do in our shoulder rehabilitation. We begin those early and often. They're a big part. I would say rehabilitation of this particular type of patient, or any type of elbow patient, typically is about, in our hands, it's about 70 to 75% shoulder and scapular rehabilitation, and about 25 or 20% of actual wrist, forearm, and elbow work. So it's a big part to be sure that we have good proximal stabilization both at the shoulder and the cuff. We do week 6, we do a lot of isotonic exercise. We start dribbling, ball dribbling, things of that nature, oscillation exercise, body blade, some of these repetitive things. And as I mentioned before, the brace is discontinued usually 6 to 8 weeks, sometimes as long as 10 weeks, depending on the surgeon. So some of our advanced stages are just week 9, initiate eccentrics, isotonic program, manual resistance for diagonal patterns. excessive amount of scapular and core exercises. Week 11, all the exercises may begin light sporting activities such as golf and swimming, which again, in a professional athlete, oftentimes that's put further in the future because we don't want anything to jeopardize their progression. Something like golf ruins their baseball career. And then at week 12 is when they start, on these particular cases, to initiate the plyometrics. 2-hand drills. Several weeks later, transitioning to 1-arm drills. So our progression is from 2-hand drills with the plyometrics initially, so there's some load sharing, then going to 1-hand drills. And then initially, interval throwing program is typically as early as 4 to 6 months, depending on, again, which surgeon you're looking at. With the internal brace, let me just go back one. With the internal brace, these are basically cut in half. So instead of doing a lot of this stuff at week 12, it's basically done week 6 to 8. So everything gets sped up by almost half in many of these particular instances. So plyometrics as early as about 8 weeks out of surgery, return to throwing around 3 months. And again, that's something that's, I think we're gonna learn a lot more about it as we move forward with the outcomes that are currently being studied and whatnot among our leading surgeons. We do some closed chain exercise, weight bearing exercises on many athletes, many individuals, but typically waiting in that 10 to 12 week standpoint. These are some of our creative ball dribbling things, like a windshield wiper back and forth, whether you use initially a Swiss ball like you see here, progressing to a medicine ball, which is obviously get more resistance. In addition to some of these plyometric drills, we can progress, as I mentioned, to a plyo ball. These are our wrist flips, where you flip the ball up in the air, isolated to the wrist. So it's just a flip, and then he throws the ball up in the air and then catches it. And then these are snaps, where the ball is snapped down on the ground and then back up. And so if you use an Airex pad right here underneath the hand, or underneath the feet, or in front of the feet, when you throw down to the pad, it'll spring back up, which then gives them that eccentric load. So you throw the ball down aggressively, ball springs up, and then you get that eccentric overpressure, and then back down to a concentric contraction of the wrist flexors. So between these are the flips right here, flipping up in the air, they catch to get that deceleration load, and then these are the snaps pulling down. So just exercises we do with a medicine ball at the highest levels. So week 14 to 26, say, boy, that's a long time. Gradual return towards competitive throwing. So beginning an interval throwing program and initiating 1-arm plyometrics, and the ultimate goal of getting the athlete back to throwing. We also do some loads around week 14 to 16 with a medicine ball, where we simulate valgus loading in the elbow. So this is just a side throw that he's doing here, throwing the ball into the trampoline comes back, and the ball gives him that eccentric valgus load, if you will. And so it teaches the individual to become, to fight against valgus overpressure. We do a lot of initial throwing, even with a medicine ball early on in the sequence, so that they can use that motion. They contract their internal rotators, and they do get that valgus load to their elbow. We also do a lot of isokinetic training, where we do wrist flexion extension, forearm pronation, supination, as being two of the wrist and forearm motions, as well as shoulder training with the Biodex. So our criteria to progression, they should be able to do at least 3-pound isotonics, have ample range of motion, and then we start with wrist flexion extension with the isokinetic machine, then do forearm pronation, supination, and then finally elbow extension flexion and the shoulder motions. So we use very fast training speeds to try to foster that fast functional contraction. So between the plyometrics and the isokinetics, we try to make sure that we're working at those fast speeds for that dynamic stability. So 12 weeks out, these are just some additional parameters that we look at as far as the range of motion and the speeds. I already mentioned these are pretty fast speed. We know from doing isokinetic testing on healthy throwers that the dominant arm is stronger in wrist flexion, wrist extension, and forearm pronation. And there's no difference in elbow extension flexion from side to side or forearm supination. So there doesn't seem to be a dominance effect in those muscle groups, but there is for sure stronger flexion, extension, and forearm pronation on the dominant throwing side. So we want to restore that dominance effect before they're back to their full activity. So this is just an interesting finding, if you will, looking at professional baseball players after elbow arthroscopy, and we look at the average follow-up at 8 weeks, we find that, see all these negative numbers. If we look, when you just have your elbow scoped, within 8 weeks, you actually have a pretty full return of your strength side to side. That's why you see people going back to throwing after having their elbow scoped or playing golf or those activities fairly quickly. However, we find that when we look at, this is 12 professional baseball pitchers, 7 with ulnar collateral ligament reconstructions, 5 with ulnar nerve transposition. The average follow-up is 18 weeks, not 8 weeks. And you see there's very few negative numbers. There continues to be fairly solid deficits of strength, even 18 weeks after the procedure. So the take-home point is, when you have an open elbow surgery, it's a lot different than arthroscopic, and it takes a lot longer for the tissues to come back, or the muscles to come back on those particular structures. Again, we do a lot of shoulder training with both isokinetics. We use impulse training, the plyometrics, all those to kind of strengthen the shoulder as much as we can. We also put the shoulder in the position of throwing on the isokinetic machine or the impulse machine to try to replicate some of the loads and stresses that the elbow will go through when they return to their throwing program. So post-op weeks 14 to 21, initiation of a interval throwing program. Is probably the main thing that I haven't already covered on that. Let's talk a little bit about the interval throwing program. So in Arizona, we're very lucky in that we can just go outside on almost every day, and we can actually do the beginning parts of our interval throwing program at the clinic. So it becomes part of their actual rehabilitation. So we do it on alternate days. We're typically seeing these patients on Mondays, Wednesdays, and Fridays, so they do it 3 times a week. And we have incremental increases in both the distance and intensity of the throwing. So we start at 45 feet, multiple days, then 60 feet, multiple days, 90 feet, we keep progressively going. Pitchers go as high as 120 before they start throwing using their actual pitching delivery, and then ultimately return to the mound to start throwing in their true pitching mechanics. Very important that we look at their biomechanics, and so we do some of that in the clinic, but we also in Arizona, I'm sure you have this here too, there are experts in our area, former Major League Baseball pitchers, pitching coaches who have knowledge on biomechanics and can actually evaluate to be sure that the early throwing mechanics are proper, that they're not opening up too soon with their hips, or they're not overstriding with their legs, or any other type of modification that would compromise their ability to come back. So I mentioned these are some really early studies. Conway at 92 looked at 56 ulnar collateral ligament reconstructions. They found they had 64% excellent results. Bennett in normal working individuals, 92, 13 out of 14 had significant improvement in just a working population. So those are really old outcome studies. This one obviously showing very good, Bennett's outcomes. The initial series by Conway was 64% equal or greater than their activity. So that wasn't as good as what we see today. Some of the new ones with the Dane procedures and the newer technology as far as advanced rehabilitation and surgical techniques show very, very good follow-up in some of these cases from a standpoint of 80 to 90% good and excellent results following the ulnar collateral ligament reconstruction. So depending on the study that you're looking at, they show very, very good returns. I mentioned probably one of the most successful surgeries to have if you're a baseball player as far as being able to come back, and that's what we're seeing in the major leagues. So some of the real important things are this incremental range of motion progression. So you don't just go first day from 90 to working into full extension. So it's this gradual kind of lowering to 30 to 15 to 10 to 5 to 0, and same thing in the flexion side. Protecting against valgus stress early on, and then it really becomes a total arm strength program from the standpoint of working on the scapula, the shoulder, the elbow, the wrist, all those particular muscles. And then the last part is this progressive throwing program, because oftentimes athletes will begin in the 4th to 5th month throwing program, but not return to throwing professionally and at the highest level for up to a year or even a year and a half. So it's a long time with a very, very slow progression. That usually isn't done under the auspices of physical therapy, other than a physical therapist who maybe works for the team. They're usually out of your clinic before you're actually seeing them during that time. But we've had patients that have stayed for 8 or 9 months after this, and so we've been involved in their throwing program, and again, slowly advancing it to be sure that they don't overstep and create any kind of re-injury. So, any questions? Yes, Dave.
I don't know a lot about throwing, but is sidearm just like super bad?
No,
Oh.
and actually, they're really, when they look at the mechanics, so the question was about, sidearm, is that a bad way to throw? The mechanics of the shoulder, the elbow, and everything are very, very similar between an overarm delivery, a sidearm delivery, and a submarine delivery. What changes the most? The trunk. So they're really, really similar. There's guys that, you know, throw from this side, and it just means that they're more upright. And where the traditional pitcher, when they throw, would be laterally flexed a significant amount to get their arm up into that position. But the abduction angle is roughly about 90, stays about 90. It's just the positioning of the trunk. So it wouldn't be something where you saw somebody say, oh, I have a sidearm delivery. It's odd. I mean, it's atypical. But if somebody had that, it wouldn't immediately be like, oh, this guy's going to get hurt. You know, it's a bad case. So.
Does that change with young pitchers though? Was there a difference? I feel like they were encouraging, you know, we're looking at preteen / adolescent boys to avoid a certain pitch, and is that similar to what he's asking?
A lot of people talk not so much about sidearm as much as like the type of pitch, meaning a fastball versus a curveball versus a slider and those types of things. And so the general rule of thumb and USA Baseball and others kind of talk about the importance of using, rather than an age with that, but a maturation level. So the idea being that they usually tell parents and coaches and stuff to wait until the kid shaves before they start throwing a curveball, because that corresponds with certain levels of growth and development, obviously. It wouldn't be a good thing to say if there's a female athlete, so that doesn't work for obvious reasons, but the idea there being that the curveball, even though the velocities and whatnot are not necessarily more traumatic, there's some belief that the biomechanics and some of the stressors of a curveball are are more stressful to the elbow, and so we actually discourage the real young players from actually throwing a curveball early on and waiting until they're more mature. So it's not so much sidearm delivery, but more the type of pitch.